It's August the 9th, 2024. This is the Room Now podcast. Hi, I'm Dr. Jack Cush, executive editor of RoomNow.com. We're smack dab in the middle of summer. Hope you're enjoying yours. Hot fun in the summertime, as they say. Today on the podcast, the title is Depends on Where You're Looking. There are several of these reports that I'm going to go over where the conclusion of the research may not be right because the results were skewed by who they're looking at and how they looked at the data. And I think you need to be careful about interpreting some of these articles and know what they really mean. And I'll try to comment on that along the way. Let's begin with a straightforward article from New Zealand, where the Rheumatology Association of New Zealand did an audit of 355 new seropositive patients referred for care. And the question at hand here is, are they getting referred in a timely manner, and are they being started by on a DMARD or a biologic within 6 weeks of the referral date? And what they showed in the 355 patients, that 65% met the stated New Zealand goals that they should be started on a DMARD within 6 weeks. The question is, what influenced that? And the main takeaway here was it was manpower, and they showed that if you had at least one or more rheumatologists per 100,000 population, 80% of people were started on a DMARD within 6 weeks. If it was less than one, it was going to be less than 65%, which is what the takeaway was for the overall study. So it's manpower that determines referrals and determines how quickly they get on DMARD therapy. They also said rurality, meaning patients in rural environments were less likely to get referred and get seen, was my take on that. So this informs our many important manpower decisions that we have worldwide: New Zealand, Australia, Europe, South America, and North America as well. And a study that caught my eye this week was a study of the association between RA and periodontal disease. As you know, that there's similarities in the biology between inflammatory synovitis and the periodontal tissues, same cells, same cytokines, same destructive potential, etc. And we do know that periodontal disease is a forerunner or harbinger of RA or worse RA. And the question is, if you treated periodontal disease, would RA get better? I haven't seen a lot of good studies on that. And this is an exploratory, smaller study of 22 patients with moderate to severe periodontal disease. And they were seen at regular intervals by dentists, got regular treatment for periodontal disease, and everybody that got treatment got better as far as their periodontal disease. But did that influence the RA outcomes? It turns out not so for the moderate RA patients, or moderate periodontal disease patients, but the ones who had severe periodontal disease had a significant reduction in DASH-28 scores and also in CCP levels. I thought that was important. So I think that the take home on this is that as part of your joint exam, you should be looking inside their mouth. As part of your counseling, you should recommend losing weight, stop smoking, and fix your teeth. That's an important part of RA management. A retrospective study from Tokyo looked at 194 Behçet's patients. How many Behçet's patients do you have? And I like these numbers because you don't see this kind of numbers, but in their review of their Behçet's cohort, they found that 25% of patients had evidence of intestinal Behçet's, which obviously is more aggressive, maybe harder to manage. Behçet's itself is hard to manage. What they showed in this study was that, and this is sort of this head scratcher here, is that if the Behçet's patients were on PPIs, that it significantly increased the odds of having intestinal Behçet's. Now, what's the connection between gastric acidity and intestinal Behçet's? I don't know. I mean, there's ulcers here that are involved with gastric ulcers and duodenal ulcers and the need for PPIs, which is not the same as the ulcerations that are seen in the mouth and gastric mucosa or GI mucosa in Behçet's. But maybe there is. I think this is one of those issues about where you're looking. Behçet's patients who are on PPIs, you're looking at their GI tract, their GI symptomatology, and hence you're more likely to diagnose intestinal Behçet's. I must say that in my many Behçet's over the years, a real minority, and I got to say 10% or less, probably 5% or less, actually had proven Behçet's with colonic, usually it's colonic ulcerations that I've found, and rarely gastric ulcerations. But nonetheless, I think this is a quizzical issue and one that's open to interpretation that can be solved by a better study and actually endoscopic evaluations of these patients to really know the true incidence. Another sort of head scratcher is comes from California and a cohort study of 19,340 rheumatic disease patients. And they basically showed that those patients who had cardiovascular events in their history, 1.4% of that 19,000, or antiphospholipid syndrome in 5.5%, these people had a greater risk of adverse pregnancy outcomes. Obviously had to be a woman and had to be pregnant and have either cardiovascular events or antiphospholipid. No problem with cardiovascular events. We certainly know they're linked to adverse pregnancy outcomes. That's really important. But cardiovascular events influencing pregnancy outcomes, I don't know about that. I think really what this is saying is that if you've got a rheumatic disease with cardiovascular events, you're more likely to have more severe disease. And more severe disease, we do know, is associated with worse adverse pregnancy outcomes, APOs, if you're a pregnancy maven. A large prospective vasculitis study in patients with Takayasu's, another large number, 236 patients, found 92% of them were women, that they were 36 years of age on average, and it had a disease duration of less than 3 years. The important point of this study was that they found evidence of vascular damage at baseline in 80% or more of patients. But what they were really doing was that they were looking at a tool called the VDI, the Vascular Damage Index, which is a listing of like 64 items, each of which has some relationship to vascular damage, but in and of itself is not evidence of vascular damage. And so I don't know what that really means using this tool, because you don't use the vascular damage index in your assessment of patients. But I do think that what was important was that even at the onset, these patients may have vascular damage, but more importantly, they will, a high percentage, 30, 40%, will develop vascular damage in the next few years. The question is, and the reason maybe why I bring this up, is how do you assess vascular damage in Takayasu's? I know the way I do it. I try to get imaging at baseline. I try to get MRAs or actually angiograms of the arch and whatnot. I do detailed pulse examinations, but you could use a tool like this to assess damage. And then how do you assess the difference of vascular damage, which may not be modifiable, versus vascular inflammation, which, you know, your pulse assessments can change, right? The angiographic stuff may change as well. So I think this is a real big challenge, and I really am looking to the vasculitis mavens to come up with better tools that are actually more useful for those of us in practice in managing patients with MPA, GPA, EGPA, large vessel vasculitis like Takayasu's and GCA. I think that's really important. And, you know, it's an important thing right now in patients with GCA and with PMR to be thinking about doing vascular imaging. Certainly, newly diagnosed GCA needs extended vascular imaging at the outset. That's part of the new guidelines. An EU study, it's a U-STAR study and another European cohort study, combined their data for 1,052 patients with systemic sclerosis to look at how often they get early immunosuppressive use. That would be methotrexate, mycophenolate, et cetera. And what they showed was that the patients who did get early treatment, which they defined as the first 3 years of scleroderma, I think that maybe is a little too late, but nonetheless, about half of them met this criteria. It was 52%. And those that did get earlier treatment were more likely to be male, have diffuse disease, and that the most common drug used was methotrexate in 60% of that 547 patients. Only 1.7% at that point had received a biologic. What they did show was that ILD was found in these patients in half the patients after 3 years. And so I think that the idea is that maybe we need to, like we're worried about RA and manpower leading to RA referrals and earlier institution. I think the same goes true for systemic sclerosis, where we do need earlier interventions. A quick note about MAS, a systematic review that I'll list for you. 57 reports, 1,148 MAS patients, almost 900 of those from JIA, 137 from lupus, showed that the most effective therapies by the analysis was high-dose glucocorticoids, IL-1 inhibitors, effective in 83% of patients, and gamma interferon inhibitors. That's emapalumab. There's only one that's on the market, emapalumab, effective in 93%. And these were especially so, and these studies were largely done in systemic JIA patients. They do say there's good evidence that supports the use for the calcineurin inhibitors, cyclosporin, etoposide, and even JAK inhibitors, and they specifically mention ruxolitinib. You may have seen the gout forecast data from Lancet Rheumatology that by this is a sidebar to the global burden of disease study that came out in 2021, that they are estimating that by 2050, and let's see, this is 2024, next 25 years, there's going to be a 70% increase in the number of gout patients. So there's 10.3 million in the United States with gout, right? As of 2020, there's 56 million people globally who have gout. The prevalence of that is 659 per 100,000. And that was already a 22% increase over the 1990 numbers. So they're suggesting this 56 million is going to go up to 96 million, all right, by 2050. And they say that the main reason for that is population growth. That's the main reason. Obesity is an important contributor, and we have an obesity epidemic, and also as is chronic kidney disease. 3 more reports. The U.S. Biobank, the UK Biobank, did an 11-year study of gout, and they said things that you know, but I think a few things worth repeating. We do know that beer and cider and champagne increased beer, cider. Who drinks cider? Champagne and do increase the gout risk almost at any dose. Certainly beer, right? But they did show in this study of 5,700 people that in women, light alcohol use was actually associated with a lower risk, a 22% lower risk. And alcohol is anti-inflammatory, even though it may impair renal handling of uric acid. Maybe in women, it doesn't drive the risk so much, and especially if they stay away from beer. And then also that light red wine use also reduced gout risk, not to the same degree. So maybe that affects some of your counseling, maybe it doesn't. 2 studies about spondylitis. A study of 136 patients referred with low back pain found that the cause was degenerative disc disease in 71, DISH, diffuse idiopathic skeletal hyperostosis, in 38, and looks like 27 patients had axial spondyloarthritis. The important part of this review of consecutive patients referred with low back pain is that the features that you find with one may be seen in the other 2. So they kind of in a very confusing way did show that when they looked at things like SPA-like evidence or evidence of SPA on imaging, degenerative disc disease on imaging, bone marrow edema, fatty lesions, that basically the SPA-like image features on radiography found in 1/4 of the patients with DISH, and that by MRI, bone marrow edema, all the patients, 1/3 of the patients had evidence of bone marrow edema, suggesting a lot of things that we hang our hat on in the diagnosis of low back pain may not be so specific. For instance, we do know the most specific MRI finding in spondylitis is going to be SI erosions more so than bone marrow edema. We've talked about that in the past. The other article I really liked, I'm going to end with, comes from Walter Maximovich and his colleagues. They did a very large study where they, 2 different cohorts, where they were studying 363 patients, and these patients were patients that were being seen in dermatology clinic for psoriasis, in ophthalmology clinic for uveitis, and in GI clinic for inflammatory bowel disease. And if any one of those clinics had patients with low back pain, they were automatically referred to the rheumatologist. Rheumatologist did his thing with a clinical assessment, SED rate, CRP, B27, conventional radiography, and if warranted, MRI. So not everybody in the first cohort got MRI. I think it was about half, but everybody in the second cohort got MRIs. And the surprising thing was that even though these patients were being seen and primarily followed in the derm, ophthalmology, and GI clinics, that sacroiliitis was found on X-ray in 34 to 60% of patients. Ankylosing spondylitis, axial spondyloarthritis, the definition by EULAR criteria, 47 to 62% in one cohort, 23 to 58% in another cohort. And the finding of spondylitis was highest in the uveitis group, right? I think you might have guessed that already, but and often a lot higher than in the IBD, or where it's about 20% maybe, or in the psoriasis group where it's probably less than 20%. Bottom line is that if they also had B27, it significantly increased the odds of axial spondyloarthritis, ranging from, I think, about 60 to 89%. And they did, not surprising, because Walter's an imaging guy and he's the expert on the use of MRI. One of the takeaways was that MRI did increase the odds of a diagnosis of spondylitis. The point of the study is for psoriasis, uveitis, and acute anterior uveitis, and inflammatory bowel disease, the presence of low back pain should warrant referral and a deeper investigation for the possibility of spondylitis. Anyway, that's it for this week on the podcast. You can go to the website to check out these citations and more. Remember, hot fun in the summertime. We'll see you next week.